A warm welcome to all of you. We're honored to have such enthusiastic bunch of people in our session, whether it's your first time attending or a returning member. Thank you so much. Before the session, I will briefly introduce SIMSOG. It is the Society of Indian Medical Students and Obstetrics and Gynecology. We are first all India OBGYN society with the motto of breaking boundaries and building hope. We are a network of passionate UG and PG students committed to revolutionize women's health. These journal club sessions are a monthly platform where we dissect papers and dive into the future and innovation in OBGYN. We hope you'll enjoy today's session. Now, over to our moderators. Dr. Ashlesha has joined us. She's a perinatal psychiatrist and family psychotherapist from Bangalore with over 2 decades of expertise in perinatal mood disorders, mother-infant bonding, and women's mental health. She's the founder director of the ARC and is a pioneer in integrating perinatal psychiatry into maternal care in India. With that, I will hand over the stage to Alfiya. You can now share your screen. The stage is all yours. Alfiya? Yeah, okay, great.
Yeah. Good evening, everyone. I hope my screen is clear and my voice is also audible to everyone. So today I'm going to present on the topic Predictors and Prevalence of Postpartum Depression among Mothers, a multinational study. So myself, Alfiya Butool, I'm a second year MBBS student from Government Medical College, Girija N. Before I start with my presentation, I would like to dedicate this study to the original authors, and it's not my original work. So with the introduction, postpartum depression. To be precise, postpartum depression is one of the most common things seen in most of the women, generally when they are married early or they got a child very late. So it is one of the most prevalent and serious complications following childbirth. 10 to 20% of mothers globally are affected with it, although the exact prevalence varies widely across the country due to difference in the healthcare access. Unlike transient blue babies, which is resolved within 2 to 3 weeks, PPD is more persistent, often lasting for months and can severely impair a mother's quality of life. PPD presents with symptoms of persistent sadness, fatigue, irritability, sleep disturbance, and feelings of worthlessness in severe cases. Even suicidal thoughts can be seen. These symptoms are not only hindered to the mother's physical and emotional recovery, but also interfere with the child long-term on the child's long-term memory and their education. The importance of studying PPD lies in the multidimensional impact. At the individual level, it affects maternal health and functioning. Though at family level, it can strain relationships, increase risk of domestic conflicts, and impair parenting capacity. Social levels contributes to a higher healthcare cost and reduced productivity. Though early identification and management are therefore essential to break this cycle, maternal and of PPD remains undiagnosed and undertreated. The reasons may be social stigma, lack of awareness, cultural barriers, and limited screening practice often prevent women from seeking timely help. Risk factors such as unplanned pregnancy, financial stress, poor marital or social support history of psychiatric illness, obstetric complaints, and infant health problems further increases vulnerability. Given these challenges, a cross-country study is vital. It allows exploration of the prevalence of PPD in diverse settings and helps identify predictors and the universally important versus those include culture, healthcare infrastructure, socioeconomic conditions. Such knowledge can guide policymakers and clinicians to develop targeted cultural sensitivity innovations. So let me say why though this study is important. A hypothesis before this study was done. For the prevalence of PPD will differ across the country due to cultural and healthcare variation, as I stated before. Factors such as maternal health problems, inadequate family and partner support, unplanned pregnancy, financial hardships, and infant-related health issues will significantly predict higher risk of PPD. Protective factors such as supportive marital relationship, adequate social networks, and often discussion of mental health are expected to reduce in the likelihood of postpartum depression. So what the question arises is the prevalence of postpartum depression among mothers in different countries, and what maternal, obstetric, and infant-related factors predict the risk of developing it. Let me start with the methodology, the study design. This was a cross-sectional multi-country study conducted across a tertiary care hospital and healthcare centers in the selected countries according to the base conditionality of the authors. 6 countries were involved in this, including Egypt, Syria, Yemen, Ghana, India, and Iraq. The aim for this study was to estimate the prevalence of postpartum depression and identify the associated predictors. The inclusive criteria include the mother's age 18 to 45 years, within 6 months of postpartum, and willing to give an informed consent. The exclusion criteria was psychiatric illness like bipolar disorder, mother with severe physical illness impairing participation, and non-consenting mother. The sample size before the study was estimated using the prevalence-based calculation. Targeted sample size per country was across 4,000 mothers, though a total of 674 mothers participated in these studies. Definitions: PPD, postpartum depression. It is defined as a depression occurring within 1 year after childbirth. And in this study, it was assessed using Edinburgh Postnatal Depression Scale. And the term blue baby I used before was a transient mood disturbance occurring in the first 2 weeks of postpartum, not classified as a PPD. The predictors were maternal factors such as age, parity, education, employment, antenatal complication. Infant factor as a preterm birth, an ICU admission and its duration, breastfeeding difficulties. Psychological factors like family support, marital relationship, and financial stresses. Going on to data collection, types of data. This all were recorded through questionnaire. Type of data: demographic, age, education, occupation, socioeconomic status, history, medical history, obstetric and medical, infant-related details, birth weight, health status, and ICU stay. Psychological variables like material support, social support, domestic violence, and financial strain. Mental health screening was done with EPDS scores. Collection method was pre-tested structure questionnaire. Speaking of the questionnaire included, after the, of course, getting informed consent, it includes study information and electronic socialization, demographic and health-related factors, then obstetric history, number of pregnancy, history of abortion, then number of living children, history of death children, test of late delivery, weight gain during pregnancy, baby's age, premature labor. Then interviews conducted by trained healthcare workers. Interviews was done by trained healthcare workers, validated skill using EPDS. A procedure and materials: questionnaire, socio-demographic form, plus EPDS. Training where field investigators trained for uniform data collection. Pilot study conducted in one site to refine tool. Consent was written, informed consent taken. Confidentiality was maintained throughout the research. Ethical clearance was obtained from institutional review boards of participating centers. The statistical analysis was done using Strata or SBS based on the country and their preferred one. Descriptive statistic frequency percentage for categorical data. Inferential statistics was chi-square test mostly used, and I think in Iraq it was t-stat for bivariates association. Logistic regressions to identify independent predictors for PPD. Significance level of P was less than 0.05, consider a statistical significant. Going on to the results. So the key findings were prevalence of postpartum depression varied between 15 to 30% across the studies sites, higher in low resources settings. Socio-demographic factors significantly associated with PPD, low socioeconomic status, poor partner support, unplanned pregnancy. Complication during delivery, cesarean section, and preterm birth increases PPD risk. These are the obstructive factors, and infant factors like low birth weight and infant illness correlated with higher PPD scores. Psychological variables like history of mental illness, lack of family support, and intimate partner violence were strong predictors. Protective factors such as good social relationships, strong social support networks, and planned pregnancies showed very low or even null PPD risk. The results about, so this is just a representation of the result that was seen. So the median age was 27 years, 27-year age, and just, yeah. So as you can see, the monthly income affected greatly to the, so sufficient income, the risk was very low. Then more than sufficient, it was like, okay, like the ratio of the PPD were very less. Though insufficient, higher risk with violence, with including violence, that means the PPD risks were higher. Even some half suicidal cases were recorded from countries like India and Iraq. Then level of education also matter in this, though it doesn't affect the whole family's education wasn't recorded. The spouse and the mothers were recorded during this study. And similarly, the low level of education, the lower the level of education, the more the PPT cases were seen. Then their lifestyle habitats like cigarette smoking, alcohol smoking, alcohol and shisha smoking were seen. So it affected the child's development as well as the mother's health. Since the study was done during the year 2023, the post-COVID period, or just the COVID were ended, so the people who got COVID showed higher level of PPD. Here is a statistical graphical representation of number of depressed patients and the normal number of patients seen. As you can see, Ghana and India showed a relatively higher ratio due to maybe due to the increased number of population, less awareness, less screening. Yeah. Then planning of pregnancy also played a vital role. Planned pregnancy shows comparatively a lower level of risk, though unplanned and unwanted pregnancy increases the risk. Further, unplanned pregnancy with lower age were seen to have more risk of PPD. Girls, usually from 18 to 22 years of age, showed more likelihood for their body structure and their performance. Means sociological characteristics and their association. As seen, the patient, those who receive the treatment, were likely undepressed or seen normal, though the areas like our rural areas symptoms were higher. Yeah. Now, cause of non-compliance, the term to be precise used. So patients were non-compliant to the treatment for personal barriers, financial constraints, geographical or regional disparities, social norms, language, and cultural traditional beliefs. As you can see, social norms and cultural traditional beliefs and personal barriers, these three were the highest reasons for doing this. Hence, the prevalence and knowledge of PPD should be spread and known to everyone. Now, the significance, statistical significance shows that with many predictors showed p-value less than 0.05 with logistical regression confirming independent association. Adjusted odd ratios for key predictors were intimate partner violence, prior mental illness, lack for partner support. In terms of clinical significance, highlights urgent need for routine PPD screening in postnatal care, suggests targeted counseling, partner involvement, and social support innovation. Early detection prevent long-term impact on both mother and child. going further on the discussion, the interpretation of the result. Please do correct me because this was personal designed by me, and I'm not yet qualified to do this. So let me continue. Discussion. Interpretation of the result. This study revealed a moderate to high prevalence of PPD, consistent with global estimates with a higher rates in low and middle income countries. Predictors such as prior mental illness, lack of partner support, intimate partner violence, and unplanned pregnancy were strongly linked to higher risk, highlighting the importance of psychological content. Protective factors, example, supportive relationship and planned pregnancies suggest that social innovation can buffer against PPD. Infant-related issues like low birth weight and ICU admission further contributed, underscoring for mother-infant health interconnection. Implication. Clinical implications include routine screening. The high prevalence of PPD justifies universal screening for depression during antenatal and postnatal visit using validated tools. Integrated care. Mental health evaluation should be incorporated into routine maternal checkups, not treated as separate or an optional one. Early identification of high-risk mother. Predictors like unplanned pregnancy, poor partner support, infant illness, or a past history of child death can help clinicians identify mothers who need close monitoring and counseling. Training of healthcare professionals, pediatrics and obstetricians and primary care doctors should be trained to recognize symptoms of PPD, provide first-line counseling, and refer when needed. Interventions, simple evidence-based innovation like supportive counseling, peer supports of group, and friends can be integrated into postpartum care packages. Public health implication. So, burden of maternal and child health. Untreated PPD affects not just mother but also the child's growth, development, family functioning. Community-based approaches. Use of ASHA workers, midwives, and community health volunteers on screen, counsel, and refer mothers as grassroots level, reducing stigma. Awareness campaigns targeting families, communities, and healthcare staff can normalize discussion on maternal mental health. Holistic maternal care shifts the focus of maternal health from only physical outcomes, safe delivery, survival, past history, to psychological well-being and quality of life. Policy of implication. Integration into national programs. Maternal mental health services should be included in the existing reproductive and child health program. Partner and family involvement is a vital role. Policy encouraging male partner participation in antenatal and postnatal care can improve emotional support and reduce the risk. Resource allocation. Government should fund screening tools, training programs, and counseling service as a part of standard. So this study's questionnaire was based on the previous research. So finding aligns with WHO estimates 10 to 20% global PPD prevalence, but confirm higher rates in low economic and underdeveloped countries, as reported in the studies from India, Nigeria, and Bangladesh. Similar predictors like lack of social support, unplanned pregnancy, domestic violence have been identified in earlier studies, reinforcing their universal relevance. Some differences prevalence varied across the site, possibly due to cultural factors, reporting stigma or healthcare system difference. As usual, there were limitations to this study as well. Cross-sectional designs limits ability to establish causality. Self-reported questionnaire may introduce cultural differences, possible recall for bias for obstetric and psychological variables. That's all. Thank you.
Thank you so much, Alfiya. Dr. Girija has just joined us. She's a professor and HOD of Obstetrics and Gynecology at Bharati Vidyapeeth Medical College and a senior consultant in high-risk pregnancy care with over 30 years of academic and clinical experience. She has authored extensive research on maternal mortality, safe motherhood, PPH, contributed to FOXI national guidelines, and leads training programs in evidence-based obstetric practice. We are very glad to have you here.
Thank you so much. Thanks, Sitan, for that wonderful introduction. Alfiya, I would like to ask you one question. You have gone through this paper and presented it wonderfully. What are the what are the key attributes of this particular paper that you have found? Because in the journal club, we also have to learn to accredit the publication that is happening in its way. If you look at the technical part of that particular paper, how would you rate it? Like, what were the things that you found that yes, this is right? What were the things you feel that no, this should have been done better?
So the first thing that I thought should have been done better was the questionnaire, because as the study included that it was completely based on the previous. The study included that it was based on previous researchers questionnaire. So I should think based on the country or the place of the living, the questionnaire should be have been decided according to the people. Like in India, there are cultural norms that lie differently. In Iraq, it would be been different. So they just took a standard questionnaire and use it in all the countries, which I thought that should have been changed. Then the things that I find it was like participation of the estimated participation was around 400 women per country, though involving 6 countries, the total participation was around 600. So that means 100 participants from per country. That means still the significance was low. The part that really I think was really marked was the detailed thing it included. Like it included from age, education, and their lifestyle habitat. Even family was consulted. Their friends were, if we see the research references, so their friends and all, everything was concerned about the mother was taken. His past history of the women were also included, and it was completely kept confidential about whom they are talking. So that was something I really liked, the confidentiality.
So yeah, that was one thing. Anything else you found technically that should have been better, or there is something that you have you appreciated that they have gone in details? Is there some technical challenge that you feel in administrating such kind of a tool?
Mhm. Technically, sorry, ma'am, but I don't think I have yet experienced such thing. But I didn't find any issue with the technical analysis of it.
Did you try to administer this tool to yourself?
Yes, ma'am.
Did you try that? Let me answer. Like, let me consider that I am a delivered mom myself, and I am now answering this questionnaire.
Yeah, I did go through the questionnaire, but I didn't saw through that perspective.
Yeah, because I'm sure you must be in clinical work, isn't it?
Yeah, just started
One of the
about this year.
challenges is getting the right answers from patients. I feel that is one of the challenges we have. So, if I may
Yeah,
know, have you experienced any postnatal depression?
yeah, I have seen few patients with postnatal depression. Like
Huh.
one was like they were limited because my limited clinical experience. But I remember one
Huh.
case. The girl was around 21 years of age, and she was like,
Huh.
okay, so my spouse doesn't support any development. He doesn't give me care and all, and my body
Huh.
shape is that may have been changed. Like mostly the young girls were preferably in like, okay, my body figure has changed, and elderly, like if they were around 30s, they were like, okay, will I be able to support future pregnancy? Will my future child will be normal due to my this physics? So those were the things I have seen.
Okay, madam, you want to ask any questions?
Can you hear me?
Yes, ma'am.
I think Alfiya, you're still a second year medical student, right?
Yeah, just started third year.
Okay. I actually just want to follow up in line of Dr. Girija's question. The difficulties that we face in clinical samples with a tool like EPDS. So one of the things you already mentioned is that it is a self-administered tool. So just thinking about a self-administered tool, what could be the problems when you ask, say, in a population like India? You are in Maharashtra, right?
Yes.
I think if you think about in a place like Maharashtra, you ask them questions that you come across in EPDS, what are they likely to fill when they receive questions like that?
Firstly, people are prone to lie because they feel like, okay, I don't want to share the
Exactly.
things. So, yeah, so they won't share what actually the cause is or what actually they are facing. All they care was their social status. Secondly, they may care about like what front person is thinking about them, like while sharing, okay, now they are going to judge to the judgmental society. And if I get treatment, so I will get, okay, I am getting a psychological. Mostly like what I have seen, like whenever someone say to go a psychological counseling, they will think like, okay, I have some mental issues, therefore they are asking me. So a social stigma of having a mental issue. So that's
Exactly. In fact, there is enough evidence to tell us that EPDS, especially the kind of questions they are, it's an Anglo sort of phonic questionnaire, right? Like the questions are, it was too much on the, I had things on top of my head. So things like that are very difficult to translate in Indian languages or non-English speaking languages. And many studies in Vietnam and similar countries have found that they need a very low cutoff to actually pick up from EPDS. So you're right that when what you pointed out is good, that EPDS just it's not just translation, but the fact that people will just lie and say no, I was fine, and then it is very difficult to pick up. Can you also think about what could be a difficulty? Because one of the things you mentioned and which is shared in the paper is that there are researchers who have been trained and they've gone in to conduct the study. So what might be a challenge when someone comes into, say a rural setting to ask questions? What are the possible?
first thing was like, okay, a unknown person is asking about my personal life. So therefore, like as mentioned, ASHA workers and midwives should be used and should be trained for that. So that can be an issue. Then communication barrier would be there. Like even if I talk about Maharashtra from one city to other city, there are differences in saying of things and communicating. So so the setting problems. So there should be someone local to help in communication, not just one
Absolutely.
person.
And so they haven't clarified who are these people who were trained,
Yeah.
whether they were researchers from like a local government institute or researchers from the main center
Yeah,
going into the field.
yeah, it was just mentioned like trained researchers were there.
Yeah. In fact, what has been demonstrated is when locals are used. So, frontline workers who already exist, when they are used, you have a better outcome in research studies. And so that is a limitation. They have used them, but they're not clarified. So we don't know if we can take these numbers seriously. So what does that tell us? Like if there is such a bias already, and already we are seeing high numbers, is there a possibility of numbers being lower than this or higher than this?
So first, it's included in primary education about this all things like a person is educated. So maybe the numbers may be low, but uh, if we see in the trend in India, so it's mostly unemployed, illiterate people ratio are more as compared to others. So maybe the numbers will rise.
Yeah. I mean, what is more likely to be possible is that frank postpartum depression numbers may not be very different to what we've elicited, because when someone is really unwell, then you're likely to have it kind of normalizes and you're likely to pick them up. But the common mental, someone who's just anxious, someone who is say having psychosocial stressors, domestic violence, may not have clinical depression at a severe level, but maybe having subclinical symptoms enough to cause damage to their personal and infant's life. Those are the ones who are going to be missed. So those numbers are going to be a lot higher and cause a lot more morbidity in the family and for the infant. Yeah, I mean, I have a lot of other comments and questions, but I don't know how you guys conduct this. Are other people also going to participate, or Dr. Girija, do you have any other
Should
thoughts?
I? Yeah. So, Alfiya, one question I would like to ask you. You went through this experience of going through this particular paper and understanding things. Does it help you in making any change in your approach to your practices, whatever you're doing in the current scenario? Does it help you in any which way? What did you learn for yourself as a clinician? Let it be in
Actually,
non-institutional, nothing. For yourself, what did you learn?
yeah, actually, I did this because I was keen in research. But I am particularly now started my research since 2 months on breast cancer screening. So I was facing most of the issue like, okay, I have given birth and I'm not gonna do this and that. So I thought that this going through this paper will help me in that screening process also. So that was my main reason to like, okay, going with this topic further.
Yeah, I will tell you my own ticket copy. So basically my own experience, like I am now practicing for last 35 years. But still, when I go through this, recently we had one lecture on brain fogging during pregnancy, which I only delivered, and I did a lot of reading. Even this paper which you have presented today, I think as a clinician, I felt that I need to be more tolerant, more accepting, more, I come from a generation where we were extremely tolerant about things. And we always used ourselves as the baseline. And we felt अगर हमने करा तो सब जहाँ भी कर सकता है. So I think that attitude will need to change as clinicians. We have to look at them from a distance, and we have to be able to understand that every person has a different way of narrative, a different kind of a reaction or a response to a particular event in the form of a pregnancy or becoming a mother or childbirth experiences. And therefore, as clinicians, I think we'll have to now broaden our viewpoints and understand this better. That, okay, fine, let's accept this. This happens. And not like the typical story that goes, the narrative. हमारे इस वक्त तो ऐसा कुछ नहीं था. अभी ये नया नया क्या आ गया? Kind of a thing. That was what was my learning from this particular paper. Scientifically, I felt that the tools were very, very cumbersome. We need to make it more simpler, more applicable, more practical, or maybe more individualized to be able to analyze. Having said that, in my practice, I'm seeing currently in my corporate practice, private practice, as well as my medical school practice, I find nearly about 3 to 4% of women requiring definite psychiatric help. They need it. So you have to be sensitive when they come to you for postpartum visits. You have to be asking them a few questions which can make you understand, and then you realize I have had clinicians who have said that, madam, listening at the voice of the baby also I can't stand. Can you just do something so that my baby doesn't cry? These have also been coming from doctors themselves. So this tells us that we have to be a little sensitive to all these kind of stuff. It was my learning. I don't know what madam also wants to express.
Yes, no, I am very, as bad as the paper might be or as difficult the tools might be, I'm excited that people are attempting these studies, right? And because that means that we do need to improve the awareness. So, just the fact that all these different researchers from different countries got together, wanted to assess. Even if the mothers have said no to many of the answers, maybe the questioning has made them think about what is going on. And if not take help from a doctor or psychiatrist, maybe take help from someone else. So definitely, I think it is a huge need that is there in India and in South Asian countries. What I feel is that the difficulty lies in not just the mother seeking help, but all the people surrounding. I think you mentioned, Alfiya, that they did a good job of asking everyone else. But what I found is, when I work very closely with obstetricians, they will pick up accurately that someone needs to be seen by a mental health professional. She comes out of the OPD clinic, OPD of the obstetrician, and even the nurse outside will say, you have to go to see psychiatrist. Why do you want to go? You're fine. So there are so many people around her between the OBG OPD and the psychiatry OPD to tell her not to go. So I think that awareness needs to improve in seeking help, in reducing the risks, because it's not just like it is mentioned very nicely in this study. What I thought was good is all the other factors. It's not just mother with, postpartum hormone drop that is causing the depression. There's domestic violence, there's psychosocial stressors, there's education, there's socioeconomic status. So many factors that are not just mother related that can be addressed. That can be addressed by, say, non-clinicians, can be addressed by policymakers, can be addressed by social workers. So I feel it needs to be a multi-pronged approach. And maybe one of the questions I want to ask you, and if there's anyone else also, like I think you mentioned in terms of training, I'm glad you chose this paper, and I wonder how much exposure do you get or training do you get? I remember my medical school training, I had nothing about any
Actually, the
perinatal
new
mental health disorder.
curriculum that, actually the new curriculum started that from second year MBBS only we have to get a clinical experience, na. So what was like first I got the posting of gynec department, and I was like, okay, the patient's family is not supporting or the mother is not. So I was like, okay, I need to know something about this department that is completely different from the rest of all. Like when I went later in medicine and surgery, people were not that non-compliant as compared to in gynec department. Most were like, okay, the child was needed a cesarean section, but the family was like, no, and our family only normal is done. And then the mother was like, okay, I don't care about anything else. I need my health to be first priority. So I was like, okay, this thing was something I never imagined will be there in the society. And it was like my first experience, like in COVID. I was in 10th standard while COVID was there. Then prepared for my NEET and just started my medical journey. So it was
It's very
completely
new.
a bit.
But
It
I
was
can
very
also
new.
tell you, absolutely, and I'm glad you are able to notice that, but you'll also see that even OBG residents and many obstetricians also don't get trained. And because they use their intuition, they have got experience in being compassionate and, eliciting history calmly, they are able to manage. But there is no exposure to understanding perinatal mental health issues even for them. So definitely what you
Yeah, like
identified.
overall 2 to 3 minutes counseling used to be done of the mothers after. And then later, like mother were like, okay, come after 3 months or 6 months for the baby's checkup, and nothing else was done between that for their assessment. So that was
Yeah.
something really very lacking.
So what is happening now across India, I don't know about other countries that are highlighted in the study, is that many states have started including mandatory mental health screening. Kerala and Karnataka, both of them, through government policy now, it is included. So Karnataka has something called the Amma card. And in the Thai card, they've introduced 2 questions that ask questions about mental health. And Kerala was the first one. They were introduced in screening of mental health in the district health program. So they're trying to make it as normal as screening for diabetes. Because if you see the numbers, I'm guessing the prevalence of gestational diabetes is also something like 20%,
Yeah.
if I'm not mistaken. So antenatal depression, postnatal depression is equal to diabetes, right? But we are not screening normally. So we need to screen. So that is being recognized many states now. I think Chhattisgarh is also introduced screening. So there is a move towards mandatory screening so that everyone gets normalized. Nowadays, if you go for pregnancy antenatal care and you tell a mother, we are going to check your glucose and you have to go for GTT, they all know it has to be done. Nobody is going to question, why are you doing this test, right? Like that, it has to become normal to ask about mental health. And that screening is now, there is a move in India, slowly, policymakers are also becoming aware, but it is a long way to go. And we are also doing a lot of training for obstetricians. Just yesterday, we conducted a training for the South Asian Federation of Obstetricians in perinatal mental health. How to screen, what are the different ways to ask questions. One of the things we recommend is that at least once or twice, you have to see the patient alone. Can you imagine a busy obstetric OPD in a district hospital? Sometimes they are not able to see the patient alone. There is a husband or a mother-in-law or someone is always with them. So just talking to her alone sometimes can give you a lot of history. So there's a lot of training that we are trying to do to sensitize obstetricians, and maybe obstetric residents also can be trained so that you become sensitized to how to ask the questions and how to refer and how to work collaboratively with your mental health professionals.
So I must share with you that some 8-9 months back, I did a certification course online with the NIMANS Institution for Perinatal Mental Health
Excellent.
certification. And that definitely gave me so many insights. While I know myself as a very empathic and an understanding doctor, because I read a lot and I generally experience so many issues with women. They have been from extremes of totally going into a Korea like presentation to a woman committing suicide. You understand? So these are very serious issues which are there, and we have to all be aware that this is a very changing arena, and as the society is evolving, social norms are evolving. We all need to adjust to those things and try to learn more and more. And I feel for all these things, we as doctors and especially women healthcare providers are the ones who are going to drive this entire movement and understand things. So
Absolutely.
therefore, we have to be sensitive, and it's so nice, Alfia, that you are understanding this in a very early part of your life, which is really going to take you long ahead. And it's very important that the youngsters understand this better and share it more often. And
Thank you, ma'am.
this legacy of understanding about women's health, having the right narratives, being compassionate about it, and especially the government taking strides, we all should cooperate. And there is this concept of what we call as the fourth trimester of pregnancy, which has been spoken a lot about in context of diabetes, as Madam was saying. But I think it's for everything else. It's also for
Absolutely.
anemia. It's also for preeclampsia. It's also for mental health disorders. And it's also for prevention of any problems in the future pregnancy, that is preconceptional care and birth control. So everything now comes, and there is this particular concept which all of us should drive, and that is the fourth trimester concept. So even after childbirth for 6 weeks, till a puerperium gets completely done with, she still continues to be your patient.
Correct.
So that has to be inculcated.
And especially, I think that's a really good point, Dr. Girija, because most of the time, what we know that most women who are generally healthy in their entire life, the only doctor they might end up meeting is the obstetrician,
Yeah.
right? They are unlikely to see any other doctors, at least in their up till their 30s, 40s. Maybe after that, if they start having other issues, gallstones, all of that, they might go to a surgeon. But the only doctor many of the women will end up meeting is the obstetrician. And within a month after delivery, they're unlikely to go back to seeing any other doctor. Whoever they go to will be for the child. Pediatricians will be focusing on the baby. So it is really the obstetrician who becomes the sole point of contact for them to pick up mental health issues or any other risk factors. And now we encourage obstetricians also to think of this like exactly like Dr. Girija said, fourth trimester. So you ask for a follow-up little bit longer than a month, 6 weeks, 8 weeks, even if it is just to check stitches which have been recovered, or let's check your sexual health, or whatever it is you want to make
As
sure
in,
that you see them.
yeah, as a universal practice, we can ask them
Yeah.
to come maybe after 15 days and align it with the baby's vaccination.
Vaccination.
And then you
Yeah, ma'am.
ask her to come back again after the completion of 6 weeks, that is after 1 month from that visit. And normally in my practice, I ask them to do a CBC or TSH, an HbA1c, and a urine routine. And many times we are able to catch them. We also can give them guidance about breastfeeding if that's lacking, and guide them about weight loss. Because that's another very big challenge that we have. Because women tend to get depressed, put on a lot of weight, and then they are unable to deal with it because there is no structured guideline to tell them what should be the pattern of your weight loss, how much you should
True.
lose, and all these things. And this is something that we need to really, truly guide them.
Absolutely.
Yes, ma'am. I do think like only not just OBGYN department, but rather the administration should know that okay, the patient has come, we have taken the history. She has the history of pregnant delivery in the past 3 to 4 months, so they should refer to all these things, just not the child or if or the other disease or symptoms that she is facing. Like it should be at
Yes,
an
my dear.
administrative
What we
level
have to
that
need to go is, I think we are all going one after numbers, two after commercials. And there is very less remaining inside. Vaccinations will happen. Babies ke liye, the mothers will go. But for themselves, they will only come if there are problems. So that's the
True.
time when, while they are leaving your hospice, like in the Bharati hospital, we have created a handout, and we give it to them, and we write a date and give it to them at the time of discharge. This is the date on which you have to come for your checkup, and this is the date on which you have to come with this test back again. But I have only 20% of women following this. 80% are lost to follow.
Ma'am, as you mentioned that usually mothers do come for their vaccination for their children. So can it happen that when they come for the vaccination, we can have like a set of questionnaires in which we can ask them then and there for screening purposes?
Absolutely. Now, this is exactly what you said, na beta, which is what I'm trying to speak to my community there. That let us have the vaccination done in the gynec OPD.
Yeah.
Do the
That's a
vaccine there,
great
ask the
idea.
questionnaire there. They don't have to move here and there and wait in two lines. In one
Yeah.
line, everything happens.
Yeah, that's a really good point, actually.
Yeah.
Moving on to the discussion, if anyone has questions, we are open to questions to both of our moderators. Okay. Actually, there was one thing which I noticed in the education level in the data which was shown in the when the people had more than the education level was more than university level or something, the percentage was approximately 15.8. Rather than it was when it was primary care or something, it was 12%. So is it because of they were not able to understand the questionnaire and the more stigma factor put into it? Because I thought it would be more in the primary if they have like primary levels of education rather than university levels, because I thought it would be reversed.
I think, my dear, this program, this entire problem is hugely multifactorial. We cannot pinpoint one single thing. One is variety, the social background, the mental makeup, the level of education. Because higher the education, higher are the sensibilities, higher are the expectations from life, higher is the exposure for, then therefore there is always an expectation and reality gap. More exposure, more gap. You see those beautiful babies in the poster. And when you're looking at your baby in the lap, which is, passing urine and passing stools, you hate it. What is this baby? What is this cranky baby? The baby looks so beautiful. So many gaps happen because you're exposed. So education would definitely make an influence, but I don't know whether towards positivity or no. It's only going to be that because I feel, because I'm dealing also with highly educated women, I feel there are a lot of problems even with them. They are the ones who suffer more from challenges during pregnancy because they have to deal with not only their families, their careers, their offices, and so many other things, and their own demons, their own understanding. So therefore, I
So
think,
another,
yeah, yes, madam.
sorry, ma'am. Finish it, then I will.
So yeah, therefore I feel that it is a very holistic. It's a multifactorial thing. There are a lot of issues which are involved into it, and therefore we wouldn't be able to really quantify and pinpoint something. We will, unless and until there is that change in your narrative or thinking or understanding, which will require a lot of time. Like I'll give you an example. Sometimes when we are while sometimes when we are talking, we feel, "Arey, ye kaisa communication hai?" And sometimes we are speaking very, very cordially and all such kind of things. So this kind of things also matter, like communications, how they are happening, what has been the experience of the birth, what has been the, like, a baby's born, a girl baby is born, and then somebody, like, they'll say ki nahi, actually no, my mother-in-law made a face. Anything can make you go mad.
Absolutely, I completely agree. Also, one of the things that what we have noticed, and maybe I don't know if this is backed with research, but if I can find some papers, I'll share it with you. If you notice the return to work time for people from lower socioeconomic status or primary education, it is not a debate. Most women need to, if they are working women, they need to go back because the socioeconomic status is such that they have to go back to work. But one of the biggest problems, say someone from a university level education, it is still hard for women to return to work. They are still expected to manage the house situation, or if they return to work, they have to manage both. So there is an extra burden on them. Whereas that seems to be somewhat like, mothers in the, at least from what I have seen, is that they have lots of other people who will be helping out, but mothers who are at university level education, that is one thing, that there is a sort of a dilemma between work and home. Another problem that we are facing, and this is probably there with all socioeconomic status, but more so with, say, someone who is educated, is that there is a lot of migration now in India. So they are less likely to have support of their family members. So before, postnatally, women would spend 6 months, 1 year in their mother's house. First few months will be there. Now it is hardly seen. Now either the mother is busy, she'll come for 1 month and go back, or the newly delivered mother has to go back to work. So that migration is another factor where the lack of support is very visible. And across education, you'll see that problem. So I think, like Dr. Girija mentioned, there are multifactorial problems. So these are some of the issues. Another big one that we realize with people who are educated is that they are a lot more conservative in sharing, right? Because they have not just stigma, but they are also embarrassed when there is a domestic violence in a highly educated couple. They are less likely to want to talk about it. Whereas, even though nothing much is done, you are more likely to hear from, say, your house help to say, my husband beats me. They will be very happy to tell you. They're not going to do anything about it, but they're more likely to tell you than your colleague. Your colleague is less likely to tell you that their husband beats them, right? So there is a lot more stigma when psychosocial stressors are there in educated people, and they're less likely to share and receive comfort and support.
Yes, and having said that, the entire community will have to rise upon accepting a pregnant woman and a breastfeeding mom in their community as well. I have so many women coming to me who are working in IT especially, or who are medicos, and then the moment they become pregnant, the colleagues are not in acceptance. They will react and respond to them so negatively. They feel out of place. Sometimes there's a lot of jealousy because there are others who are not able to get pregnant, or sometimes there is non-acceptance कि अभी ये कुछ काम की नहीं रही, हमको कोई दूसरा replacement चाहिए. And then when will she take leaves, and if she takes leaves, then her job will have to do. So all such kind of things are also there. And therefore it has to be a complete understanding and acceptance. I was just now in conference in Chennai, I must share with you, and there were two people there, bureaucrats who were, and then an MLA who were called as chief guests, and they expressed concerns saying that in the state of Tamil Nadu, the total fertility rate has reduced so phenomenally. The government, and we know that even the Hyderabad, Telangana government is encouraging women to have children. And because the population is reducing so drastically, because nobody wants to have children now, because of these challenges. And I was then thinking that it's not only that we have to protect the women, but we also have to protect the healthcare providers. Because there's so many healthcare providers who don't want to become gynecologists because of litigations, issues, problems, and things like that. Accordingly, there's no family life, there's no social life. So it's going to require a lot of churning. And if we really do not get into this bus right now, we are going to have a problem. Our entire population policy will have to be changed across the country. And the fear that the southern states expressed was there'll be so much of population coming from the northern part of the country looking for jobs, and the south countries will be completely extinct. Now, this is something which requires a thought. And this is a reality which we are facing right now. And there are certain communities where there is no, there is no restriction on the number of children that you are going to have. Well, there are so many learned couples who don't want to have any more children. They say it's too much of a hassle. We don't want it. So there's a question which has been asked. Now that you've diagnosed the PPD, what do you do next? First and foremost, find out if there are any organic causes. And there are many times categorization which can be done. And we can consider using SSRIs. There are quite a few serotonin receptor modulators which are found to be effective and not coming in the way of breastfeeding. But it's always better to take a team building with a psychiatrist, because they will help you better. Many times in our community, what we take is, in my clinic as well as in the hospital, we are using a psychologist in the middle. So there is no stigmatization that there's a psychiatrist seeing you. That can be done.
Yeah, and I think I completely agree with Dr. Girija. Working closely with a mental health professional is very helpful. You can use a counselor, psychologist, What is also helpful is, and some hospitals are beginning to do this, is to connect the mothers with other mothers and have support group, because often they are more likely to listen to advice from other mothers, and at least their sharing and connecting with other mothers can be very helpful. So that can be another thing additionally you can do to support them. And another thing is that whether you treat the primary, I mean, the underlying depression, but you also can take care of, say, the psychosocial risk factors. If that is, there is, what we know, there are risks, like if there's unemployment in the husband, if there's alcohol use in the husband, those actually impact on maternal depression. So taking care of the extra factors sometimes may be easier than getting the mother to straight away see a psychiatrist. So you can start with that. Once that intensity of those things come down, then she may be more amenable to get counseling. And sometimes family counseling can also help, getting the husband and wife together to talk to someone can also be very helpful.
We have the question in the chat if you could start with antidepressants, or we could do something else before that.
So like Dr. Girija suggested, definitely if you have access to a counselor, it's actually advisable to start with counseling. It really depends on the intensity and severity of the depression. What we do know is if you don't do anything, then that is going to affect the quality of care that the infant gets. And maybe the infant will get taken care of by other people, but the mother will miss out on the, initial precious moments of bonding with the baby. So it's important that something is done as soon as possible. If you are, I think it's probably best you work in collaboration with a psychiatrist before you prescribe medication, but SSRIs are safe in breastfeeding. In fact, there is less SSRI component, I mean, a percentage that passes through the breast milk barrier than the placental barrier. And we know that even in pregnancy, we can prescribe SSRIs now. So you can prescribe postnatally without any hesitation. You will face more resistance from the patients who may not want to take the medication. So you're more likely to, find some benefit with engaging them with a counselor or a psychologist first. But if the risk is high, they're suicidal, if the depression is very severe, they may not even be amenable to engage in therapy. So in that situation, you may have to consider medication, and maybe even work closely with a psychiatrist, get a psychiatry opinion to see which medication can be helpful. Another thing that can be really helpful is to protect their sleep. Sometimes improving their just uninterrupted sleep is a luxury for most mothers. So even if they start getting a few hours of uninterrupted sleep with active support from the family members, those are like, ways of supporting the mother. Pumping and allowing someone else to feed the baby so that the mother gets sleep. Getting others to help out with household chores so that the mother can have rest. So those things can really help in reducing the external factors, but definitely consider therapy. Like, we know that evidence-based therapy like CBT, interpersonal therapy, or just supportive health psychotherapy can be very helpful. Connecting them to other mothers, like I said, and reducing any risk factors of, say, violence, addiction in the family members.
Ma'am, what I think personally, like I do not have experience, but what I think, like most of the mothers are like, okay, you are giving me certain medication. Already they are in early phase of depression. I don't know about the late phase, but in early phase of depression, what they are like, okay, if I take this medication, it's gonna affect my child. Though we even explain them like what non-compliance is basically, then too they are like, okay, no, this is gonna affect, and then the society is like, okay, no, you are gonna take this medicine, it's name like this, it's used in this things and all. So it's definitely gonna affect the child. So the major stigma with depression that mothers have is that their child may be affected because of them taking any kind of treatment. So,
True, and that is the biggest challenge we have right now. What we also need to start talking to our mothers and families is the side effect of illness. Everybody is worried about side effect of medication. Nobody talks about side effects of illness. If she is depressed, then actually the impact on the infant is huge. It actually affects the growth of the infant. It leads to long-term problems in the future. So if that is talked about, and educated to the husbands and to the other family members and to the mother, then that can be something that is, I mean, of course, we can only increase the awareness and improve the education to allow that to happen. But you're right, it is a barrier to overcome, and we are slowly chipping away and trying to overcome that barrier.
Okay, so we have another question, that is, what is the difference between postpartum psychosis and depression?
So postpartum psychosis is usually seen within the first 2 weeks. It is more of an acute condition. You will see psychotic symptoms, like the mother can be paranoid, she can have delusional ideas. So reality distortion is seen. Her ability to recognize what is real and what is not real can be distorted. Sleep is disturbed. There may be postpartum psychosis is very closely linked to bipolar. They may not have a history of bipolar, but there may be a slight manic flavor, increased energy levels, increased sort of driven behavior. They may not be very elated. You don't see that elation very often, but that may be there. But there is a lot of driven behavior. They're not resting easily. They're restless. And like there is reality distortion. In rare cases, they may hear voices, but what you most commonly see is paranoia and refusing anyone to be near the baby, or believing that the baby is, say, possessed, or someone is trying to possess their baby. So definitely seeing symptoms that are far removed from reality. Whereas and it is most commonly presenting in the first few weeks, most commonly in the first 2 weeks. So it's almost called puerperal psychosis. Whereas postnatal depression, postpartum blues, you will see very soon in the first 2 weeks, and it is where they're over emotional and overwhelmed, and they just cry, and they just, everything feels too much, and it settles without any intervention. It will settle within 2 weeks time. But postpartum depression actually starts presenting when all the initial chaos has settled. 6 to 8 weeks is when mothers start showing signs of postnatal depression, and it's similar to what we see in depression. They're not able to sleep even when nothing is required to be done. Baby is asleep, all the jobs are done, but they're not able to sleep. Their fatigue levels are higher than what you would normally see in a postnatal woman of that stage. They are either anxious around the baby, so they're keen to pass on the baby to other people, or they're anxious to keep checking on the baby. They're hyper vigilant. They have constant ruminations that they're not good enough. They're like, why have I made this? Why did I become pregnant? I'm not a good mother. What did I do? I shouldn't have done this. They have regrets of having becoming pregnant. They also find it hard to, say, bond with the baby, or they think they're not a good mother. So a lot of negative sort of thoughts, low self-esteem, not feeling like they're good enough mother. Um, of course, in severe cases of postnatal depression, you may see suicidal thoughts as well, and thoughts of maybe wanting the baby also not to be there. And I can't tell you how common that is and how reluctant mothers are to talk about it. They're scared. They're scared that they have those kind of thoughts. But it's very common to feel like, I wish the baby was not here. That doesn't mean they want to kill the baby. They just like, what have I done? I wish I could go back to the pre-pregnancy stage. So the postpartum depression, you'll see a lot of reduced appetite. Everything is slowed down. Everything is low. Postpartum psychosis is definitely reality distortion and very agitated kind of behavior. And postpartum psychosis is a little bit of what we call a psychiatric emergency, should be treated immediately, and definitely try and get help with a psychiatrist. You can use an antipsychotic such as olanzapine or quetiapine, a small dose to help them. Any tranquilizer at that time is okay to bring them down, and then consult with a psychiatrist. Sometimes they may need an admission either to a psychiatric ward or a mother baby ward. I mean, in sort of, say, a middle income family or a high income family, they're very reluctant to get admitted. So sometimes you may have to, include family members to be vigilant, to make sure that they're, taking care of the mother, and explaining to them that this is very closely hormone related, is what I tell them. When the delivery happens, the hormones have crashed, and so the mother is not able to manage. You just need to support her till she overcomes this phase.
So
I don't know if Dr. Girija wants to add anything.
I think she's traveling.
Yeah, she's traveling.
I'll move on to the next question. We have, do you think that starting support group early in pregnancy
To ask me, I am here if you want to ask me anything. Okay? Yeah.
So the last question is that do you think that starting support groups early in pregnancy would be more beneficial, and is it possible in an Indian setting?
Yeah, definitely. I mean, the amount of mothers I see who start forming their own support groups. In fact, they will seek out unscrupulous support groups through Facebook and Insta, and they get all sorts of advice, which is not very helpful. So, if you are able to start one which is a little bit more guided and better advised by professionals, that is actually good for them. If you look at, there are many Facebook groups, some mother group and breastfeeding group. There are lots of groups that mothers are already there. They're already online. They're asking each other. They're asking for advice. Then there will be an admin saying, please don't ask advice about your baby's rash, because they're asking things like that, which is just not right for them to be asking other mothers. So they are already there. They're already seeking. So if we are able to give them support from better moderated channel, that is very helpful. In fact, if you start it in pregnancy, most antenatal places have antenatal classes. So that might be a good place because they're mothers with similar level of pregnancy. Then they can continue having, periodic meetings. That can be a good way for them to relate to each other and continue supporting each other. So that can be a place where you could form an antenatal support group for them.
So, well,
Challenges such as even the pregnancy events sometimes cause a lot of challenges. If she has excessive hyperemesis, or if there's something, the baby is not growing well. So these are also influencers. But having said that, I have one particular such kind of a service in which I enroll patients who agree to get enrolled into it. And we find that every patient till the end of pregnancy, per patient has at least 150 to 200 queries to ask.
Absolutely.
That means our social structure is not supporting these answers. There is a huge disparity. They are highly educated women, but their families are not so educated. So they can't fall back on the family for these support. They either have to fall back on the social media, or the doctor, or such services which are there.
Agree.
that was a very light discussion. That kind of brings us to the end of this discussion, cutting short maybe. So the post-event questionnaire is in the chat box, which is compulsory for certificates. So everyone here, please fill that. And those who have paid, so will get the certificates. And thank you so much, Dr. Ashlesha, Dr. Girija, for joining us, and Alfiya for presenting. It was wonderful to have this lively discussion. And especially, ma'am, when you're traveling, thank you so much for accommodating with us.
Right. Thank you so much, and nice to connect to all of you. And it was such a wonderful topic to be discussed. And Dr. Sesha, so much things I learned from you as well. Thank you.
No, you as well. Thank you. I'm really glad to
Thank
have
you, ma'am.
been a part of this. And Alfiya, job you have done with the
Yes.
comprehensively summarizing the paper. Well done. Yeah, thank you very
ma'am,
much,
for
everyone.
your insights.
Thank you.
Thank you so much, everyone.
Bye bye.
Please remember to fill the questionnaire.
Bye.